And you have time, so if you have a lot of cases, you can take some more time since there's.
Okay, yeah, I need 10 seconds here to get rid of a couple of HIPAA windows before I share my screen. So just a couple seconds.
I can start if you want, Jeff. Whatever works.
Okay, well, I think
yeah, go ahead and switch to David for a moment. That'd be good.
All right.
Thanks.
Okay, people see a rentgenogram?
We do.
Okay, so pretty normal looking here. You know, don't really see much. There's a little mystery about to be disclosed down here in the right lung base. And it is this bubbly lesion down here. Looks like a big component of emphysema. Some strange looking bronchial elements here in the middle of this whole thing, and a systemic artery. Let's see, I should be able to change windows here and show you that this is an enhancing vessel. We do have a, let's see, soft tissue window. There was a contrast study here that lights this vessel up. So we have an arterial branch here coming off the descending aorta that goes into this bubbly lesion down here. Let me show you too on coronal here, because it really helps to bring out the definitely bronchial shape of these, some of these abnormalities here. So this is the first time in the sequestration where I've seen things that really look like bronchi. And the question is, where does this radiate out from? Where does it originate? I almost thought maybe it's coming off down here near where the aorta is coming off. And that would be great, because then we'd have an artery accompanying bronchus, just the way the pulmonary artery accompanies bronchi. But no such luck. I can't really tell where this thing starts. It seems to be, maybe it's radiating from a hub here, downward and medially, but this does not connect up with the native airway. This lesion was resected, and it was a sequestration. And they described cysts lined by bronchial epithelium or endothelium. So this is a very nice sequestration in showing definite bronchial forms here, sort of rudimentary bronchi. I've never seen this before. So I don't know that you guys have encountered something like this that really looks like bronchi, the sequestration, rather than just some big cysts.
So,
you know,
David, I was reviewing a paper. I was putting together a lecture on congenital anomalies, and there's a strong association of, you know, because some of this looks like it has CPAM components. You've got the sequestration with the supply, but it also looks like this is probably an area of bronchial atresia. There's frequently coexistence of all of these, and it kind of makes sense. The lung bud doesn't form normally, so you're left with the airway bits that aren't connected. You're left with the vascular bits that don't regress, and then you're left with the parenchymal, for lack of a better word, bits that don't develop normally.
Right. Okay. I mean, they didn't describe any CPAM-ish stuff. They really, you know, and I've seen this emphysema surrounding a more central dense nidus before. I don't know what to make of that. So, yeah, if you wanted to call it CPAM, or even congenital lobar emphysema, you know, which doesn't have to be lobar, and it's now called overinflation, would explain the big patch of emphysematous looking lung.
But you mentioned they saw cysts, and that's with the Stalker ones. They see macroscopic, or they see big cysts in the lung specimens. I think some of it may just be semantics.
I think so. Yeah. Okay, but this is the first time I've ever seen a nice branching pattern like this, a truly bronchial branching pattern.
Yeah, those are more developed than often you'll just see. Sometimes I've seen a couple that just have like a single bronchus, but that's a really nice example.
Okay. So here's a fellow who's had, as you can see, a resection of his right shoulder here. He had an enchondroma, and then that was curetted and stuff like that and plated. This was in the scapula, and then things recurred and it turned into a grade 2 chondrosarcoma. And he has lung metastases. So at this point, this is current imaging here. last month on this guy with all these lung metastases, but they have, some of them have an interesting shape, and that shape comes out nicely here, I think, with CT. Let me actually show you the standard window here, soft tissue window, and you can see that these are really end arterial or intra-aortic, sorry, intravascular, really intra-arterial metastases that have grown along the these arteries. These are the fattest, most pronounced end arterial metastases that I have seen. We've got them on both sides, more on the right than the left, but clearly within vessels and branching out all over the place. And this comes out nicely, I think, with the coronal views here. You can see this vascular pattern of filling here with this metastasis. Now, I went back to an earlier study in 2016, so about 2 years before, and there were mostly peripheral lesions. So I think that what happens is that probably the metastases large are distally, where their caliber, interrupts the pulmonary artery flow, and then I think they grow retrograde back up through this big empty space, and they're getting blood probably from the pulmonary artery flow as they go. So I think they probably start peripherally and then grow centrally like this, just given the way small metastases would go out more to the periphery. And the succession on serial CT scans also supports that we started out with these smaller lesions like these up here, and then things developed more proximally, I think, from those lesions. So if there are big chunks, of course, they could lodge more proximally. So we have to consider that possibility too. But I don't think there was venous access for this to send big chunks to the lung the way, say, a renal cancer or hepatoma could do, or even an adrenal cancer that got into the veins. So very large metastases here in an intra-arterial distribution. Okay, and then I wanted to show this case of what is called Paget-Schroeder syndrome, also known as effort-induced thrombosis of a subclavian vein. And so this fellow, let me show you, this is an early view here where this person has a little bit of narrowing here where the subclavian vein crosses the first rib. And then with manipulation, so they had this guy use his right arm and they repeated the study, and you can see at this point the degree of obstruction from, I don't know, swelling or from moving the arm or something like that has become much more severe, and you can see that there's no flow really across this subclavian with manipulations. I'll have to read about what the form of manipulation was, whether it was just moving the arm or what. So this fellow ended up having a resection of the first rib to free up that space. So this is attributed to muscle swelling or muscle hypertrophy from having big muscles from, say, mountain climbing. This guy was a mountain climber. He liked to hold onto rocks with his fingertips and stuff like that. And it may be positional partly. It's a kind of thoracic outlet or inlet, I guess in this case, syndrome that involves pressure on the vein. So have you guys heard of Paget-Schroeder or heard of this effort-induced thrombosis syndrome with that?
Yeah,
name?
It's a favorite boards type question. I remember it from when I was a resident in the IR section.
Okay.
Well, we do a fair amount of first rib resections here for thoracic outlet syndrome. So I think it's just, I presume it's in the umbrella of the
right.
Yeah.
Yeah.
And it
happens a lot in pitchers too, and a lot of major league pitchers have gone to St. Louis and had surgery for this. One of the surgeons there, when I was at Barnes, does that.
So there was one other case I wanted to show you guys. Let's see. I think I showed you that one. Okay, let me show you this one. Okay, this, we'll get rid of this. This woman has a pretty normal chest radiograph. She's 36 years old and her aorta looks normal. But you can see that let me show you her CT. She has this modest dilation of her ascending aorta, and she has quite a bit of dilation down here at the level of the sinuses here. So they measured 4 centimeters on their special measurements that they do across this. And this had increased slightly. She'd been followed for a couple of years because she carried a diagnosis of Marfan syndrome. She's not that tall, so she doesn't really have the Marfanoid shape to her body and stuff like that. So they eventually got genetics on her. And it turns out that she has Louis Dietz. And this is her 3D reconstruction. She's got this modest ascending aortic dilation, very, very slight, but mostly effacement of the sinotubular junction and dilation of the sinuses. So they took her to surgery and did an ascending aortic replacement. And then the path specimen came back from her ascending aorta showing degradation of the collagen and stuff like that. So it came back as, you know, what they would call cystic medial necrosis, and that's consistent with this Louis Dietz thing. So she had the genetic studies, and she has the TG something or other tissue growth factor deleterious mutation. So she's got Louis Dietz genetically. So you know, this aorta was not very impressive to me. For a 36-year-old, it's a little bit dilated, but it had increased on serial echoes, and so they intervened quickly because these people die early of dissection and aneurysm rupture. Her mother had died, I think, at the age of 45 from a ruptured aorta. So it's autosomal dominant, and she's got strong family history.
Yeah, I've read as small as 4.2 centimeters they'll operate for Louis Dietz. And of course, that's not a hard and fast number, but certainly smaller than what you think of with even Marfan's, but usually, you know, bicuspid aortopathy and other abnormalities.
Right. So I think the sagittal view here best shows this modest ascending aortic dilation, like through here. And you can see the effacement, once again, of the sinotubular junction. Okay, those are the cases.
All right. Thank you, David. All right, Travis, you ready now?
Yeah, let's. All right, you see a scout from a CT.
Yes.
This just came into our pediatric congenital conference this week. This is a patient, this was done outside. She's 20 years old. She has a vagal nerve stimulator for refractory seizures and other neurologic issues related to her underlying syndrome. And David, this is nearly identical, but probably not as good as the case of this abnormality you showed. And unfortunately, I don't have a radiograph. Looks like she has a left arch here, but then you see there's this higher right paratracheal abnormality, and the trachea looks like it's a little deviated to the left, but it's quite an impressive CT when you see it, that her arch is right-sided and extremely high, and she has, as the case you showed either last week or the week before, the circumflex descending aortic arch that descends on the left side, and the left subclavian comes off of the descending, so it's an aberrant subclavian as well. And so this is a patient also with DeGeorge syndrome. I think, is that what your patient had, the one that you showed?
That's right, it was DeGeorge.
Yeah, with a 22q11 deletion. And I think this is probably the most convincing cervical arch I've seen, not quite as high as yours. The other thing is too, you can notice how early the carotid bifurcates, and some of the cervical arches you'll have separate ostia for the external and internal carotids, and it's nearly what the case is here. But they had referred her for potential surgery. They wanted, I don't know, she has other issues too, to correct her vascular ring here, but it's such a complicated arch, and she has other issues that the surgeon deferred. But you can see how high the arch is. So very similar morphology to the one you showed a couple of weeks ago.
Very cool.
So that was a quickie. This one I've been saving. This was from a few months ago and just never got around to showing it. And this is a lady that came in October, and she had been transferred from an outside hospital with relatively acute onset of respiratory failure. And this was right around the time that they had the bad fires in Napa. And this lady had been subject to some smoke inhalation, and they thought that might be precipitating some of her issue. And so she's 36, had had a little bit of a viral or just some sort of upper respiratory symptoms that had been attributed to a virus or to some community-acquired pneumonia about a week before, and then had the fires, and then she presented like this to the outside hospital. And so she had this PE study done and was transferred to us and billed as, you know, severe aspiration or smoke inhalation, which I don't, you know, I was a little skeptical of that. And you know, she's got symmetric bilateral lower lobe consolidation. Some of it even, you know, some of the areas are a little bit more nodular, yes. But, you know, a couple weeks went by and she wasn't getting any better. She had a repeat study, and now it looks more like you have some areas of organizing pneumonia, and in the lower lobes, you have a little bit more confluent consolidation, a little bit of dilated airways here. And so this was, you know, they were just treating her for pneumonia, what they thought was pneumonia on top of this. And at this point was when, you know, I was talking to the pulmonologist and raised the question, you know, does she have any underlying connective tissue disease? Is this some sort of, you know, organizing pneumonia or something else? They went and questioned her, and she actually, they found that she had a very strong history of rheumatoid arthritis, and checked a whole panel, including, you know, we talked about antisynthetase syndrome, just given how extreme basilar predominant this was. And this did turn out to be a case of anti-Jo1 antisynthetase syndrome. And her, you can see her Jo1 was positive. And she didn't have rheumatoid, all of her CCP and her rheumatoid factor were negative. But then they treated her with steroids, and you know, a month later, she's gotten, you know, she's not back to normal, but she's much better. So there was a lot of discussion then too. And there's a lot of theories, I think, on this, and I'm curious what you guys think, but a lot of times I think our pulmonologists believe that you can have some sort of environmental exposure that triggers an underlying autoimmune disease to really manifest. And there's been some data suggesting that from first responders at the World Trade Center, that it may, you know, some sort of lung injury may precipitate this. I'm curious what your theory is to that, but it's certainly a good look for antisynthetase syndrome, just with this lower lobe predominant consolidation. And of course, if you had PATH, it would be a mix of NSIP and organizing pneumonia on these cases. But you know, it's one of those ones where I'm always skeptical of it being just a run-of-the-mill pneumonia when it's so symmetric like this. So I don't know if you guys have any comments or not.
What about your comment about the precipitate? Maybe it may make sense for lung dominant connective tissue disease. I presume she didn't have any other organ and systems involved.
No, and there have actually been, in our pulmonology, one of our pulmonologists was talking about there are cases even of renal disease, some of the pulmonary and renal syndromes, like Goodpasture's, that may be precipitated by some sort of exposure, and then they get to lung disease, and then they develop antibodies that also attack the kidneys.
Yeah, I think it's been linked to cigarettes.
So, yeah, that may be what it is.
I think also to marijuana smoking too.
Yeah. So this case came in around the same time too. This was a couple weeks before that, and this lady had a little bit of a different presentation. She's a little bit older, but again, on the radiograph, you can see fairly symmetric opacities in the lower lung zones. You know, a little bit of blunting, maybe small effusions, maybe just consolidation. Of course, undergoes the requisite PE study. And you can see at this point, she already has a little bit of dilation of her airways and presumably some traction bronchiectasis, that some of this is irreversible. But it's a very similar appearance to the second CT on the other lady, with lower lobe predominant consolidation. It's a very striking lower lobe distribution. And this was another patient who was being seen. And of course, you know, one of the things to test would be an antisynthetase panel in her. And in her, it was actually, this was a PL7, so one of the other antisynthetase antibodies. So JO1 is the most common, PL7, PL12, others are also seen, and they're usually mutually exclusive, where you'll only have one of them positive in these cases. And then you can see she had some other issues. It started with her respiratory symptoms, and then she's developed a rash, had more of the myositis and stuff present later, but just another case of an antisynthetase syndrome. And then she was treated as well, and I think her little bit of the consolidation got better, but that underlying traction, this extreme basilar predominance of these findings persisted after treatment in her. So another antisynthetase syndrome. Let's see, this one. This is one where I think this was originally picked up on an abdomen and pelvis CT. And actually, no, there was nothing here. This is 2008. Nothing in the left lower lobe. 2014. This is just, this is more of an interesting and curious case. This nodule was seen in the left lower lobe, and you can see that there's some internal calcification. It has central calcification, what you'd describe as probably a benign pattern of calcification, except this nodule was new. There's a little bit of a irregular margin to it. And I don't even remember why. I think this may have just been lung cancer screening that this patient continued to get followed. But it's interesting is that you can see that from 2014 to 2017, it substantially grew. And the little focus of calcification really stayed pretty much the same. And it was, of course, it was new from the older studies. And so that prompted a little bit more evaluation in this case, because occasionally we've seen reactivation granulomas where you have an infection that then develops soft tissue around there. Occasionally adenocarcinomas can have a little dystrophic calcification. This was 2018. It was watched, a little bit more calcification in it. Finally ended up undergoing a PET, and there was very minimal metabolic activity. It was a less than 2, SUV of less than 2, as you can see on this PET image. So they took it out. This was the only thing in the lungs. Any guesses as to what it was?
Dirofularia.
Good guess. Yeah.
Was it Cox?
It just turned out to be an amyloid. It was an amyloidoma, just amyloid.
Huh.
And no, what's curious is I was reading the report, and it was just deposition of amyloid, and there was no comment on the presence or absence of a lot of plasma cells in there. Of course, I wish Howard was on here to comment, because I'm guessing there must have been some sort of cells in here secreting the amyloid to cause it to just collect in this area. Or I don't know. It also begs the question, could there have been an infection like either of the ones you suggested that caused a reaction where the protein was deposited? But certainly not the typical look of amyloid that we see, even in the lungs.
So I think, so the big amyloid nodules tend to be in the lower parts of the lung. They can have some emphysema around them, as Howard has emphasized too. So yeah. I think and it's ossification probably. The calcium is probably bone. Did they comment on that one? Bone?
No, I didn't look recently. I don't remember. That's a good point though. Yeah, you're right. It's usually bone, and then you can have cysts even. Of course, what we often see with amyloid. But yeah, this was the only location. So a solitary amyloidoma. So just more of a curiosity than anything else. All right, next case. David, you'll like this one. This is one that I saw a couple of years ago, and I've been waiting for PATH. And it turned out that I guess the primary team agreed with our assessment and never even got PATH. So this is a patient who's 43. And you can see he has a lot of bone abnormalities. He has this big expansile lesion in a right-sided rib, this big expansile lesion in his mid-left clavicle. And as David likes to always point out, he has a little bit of distal resorption of both of his distal clavicles at the acromioclavicular joints. And he had that, and you can see, maybe you can see on the lateral, maybe you can argue there's a little bit of a Rugger Jersey spine. This is a patient with long-standing end-stage renal disease and, as a result, hyperparathyroidism. And so I read this CT. He had been transferred in with somebody had questioned whether or not he had metastatic disease, and you can see something in the scapula, this clavicle. But I thought he didn't have a history of a cancer. I figured these were all just brown tumors. And you can see even in his vertebral bodies, and this was back in 2016, he underwent a renal transplant last year, and I think the transplant team agreed that they were probably brown tumors and never even felt the need to biopsy one of these. So I was hoping that they would, just so I could have proof of it, but I think that's probably what it is in the setting of long-standing end-stage renal disease. Would you agree?
Travis?
I've not seen a case of brown tumor of my own here. I've only seen a couple that other people have, like Tom sent one a few years ago.
Yeah.
I'll take your word for it. But
I think you always comment on the distal clavicular resorption.
Yeah, this is a beautiful.
Oh,
it should be
and right here too. The the acromioclavicular what is
coracoacromial.
Yeah.
Yeah, that's perfect. And then the spine, regardless of whether you think there's rugger jerseyness there, the outlines of the vertebral bodies are fuzzy. So the fuzzy stacked marshmallow look of the vertebral bodies is renal osteodystrophy. So you don't have a sharp corticomedullary interface, and that's why the outline of the vertebral bodies is so fuzzy here. So that's
okay.
Part of renal osteodystrophy.
There.
Yeah.
Jeff was going to say something.
I was going to say a couple things. First of all, I've only seen the brown tumors with primary, I think, well, maybe with renal, but mostly with primary hyperparathyroid. The second thing do they get better if you correct the renal disease? Do they?
That's a really good question. I have no idea. This guy's he's had a renal transplant. He's had renal transplant ultrasounds, never had another chest imaging since 2016. At least not at our institution. So, and he's still alive. So it's not multiple myeloma. They did do a bone marrow biopsy at some point, and as part of their transplant workup, I think.
I love it.
But yeah, but I thought, especially with some of those other findings, I forgot the acromioclavicular or the coricoclavicular ligament, I guess is what's right there. Yeah, that you've commented on that in the past.
So, Travis, do you think that was a pathologic fracture on the left at the coricoclavicular joint? And
that's a good question. And then it's a big expansile thing. Yeah, but you're right. It is in the region on the left. I don't know. Or if it's just the same thing that just was much more exuberant on the left. I don't know. But like I said, I waited long enough for PATH, but I was following up, and he's been transplanted. So that's what they think the diagnosis is too. This is another. I've got a couple of quick radiograph cases, just some nice subtle radiograph findings that, if you know where to look, you can make the diagnosis. This one kind of reminded me at first of your aortic case that you showed. And you can see in this case that there's a big right paratracheal abnormality. And sometimes you just have tortuous vessels or increased mediastinal fat. There may be a little bit of mass effect on the trachea. And when you look on the lateral view, you can clearly see that this is not just the run-of-the-mill tortuous vessels, because look at what it's doing to the trachea on the lateral view. This is a nice obliteration of the retrotracheal space, or Rader's triangle here, with the trachea being bowed anteriorly. In this patient, this was done at an outside hospital, and I think this had not been picked up. The patient was having chest pain and dysphagia, eventually underwent a CT, and you can see accounting for that. And it's amazing that he had all of this right paratracheal lymphadenopathy. This was a couple weeks later. But just the primary mass here with that forward bowing of the trachea, and then all of this right paratracheal abnormality as well. So both a nice finding, but also goes to show how much of that can hide, as you see this, or how subtle it can be, unless you know where to look.
Travis, what was the tumor? Your sound dropped out for a while.
Oh, it was a primary esophageal tumor.
Okay.
It went from the proximal third of the esophagus. I don't remember if it was squamous cell, or probably, given the location, I don't know that for sure. And then there was just paratracheal metastatic disease and other nodes that were involved. but nice. You could just see the correlate with the radiograph of that anterior displacement of the trachea. And then one more subtle radiograph. This is kind of an interesting one. That this was a patient who was presumptively diagnosed with pneumonia. I think this was done at either in our ED or somewhere, but whoever read this just saw that there was some asymmetric opacity in the right upper lobe. It was, you know, back in December, flu season. Thought maybe this patient had a pneumonia. There's a few issues with that, and no comment was made on the lateral view, but I think we can all recognize a few things here. A, subcarinal space is filled in. Really, this is the left main / left upper lobe bronchus continuum here, but you don't see any of the right-sided airways. There's no intermediate stem line. And then you can see this big opacity projecting backwards. So left pulmonary artery should be in here, but this is way too much for just the left pulmonary artery. And when you look back on the PA view, you can also see that looks like there's a little bit of splaying of the carina, probably a little bit of narrowing of the left main stem bronchus, and then just something occupying the azygoesophageal recess. It's just in the subcarinal space like we saw. And so she was treated with antibiotics, didn't get any better. Of course, the delay of a month doesn't really change anything in this case. This was an enormous small cell carcinoma. At this point, you can see the right lower lobe or bronchus intermedius is almost completely obliterated, but the correlate for what we saw in the radiograph at that time. And I think probably what they were seeing on the original radiograph is what we see here, which is just likely a combination of venous and lymphatic obstruction just from this huge tumor taking out the right superior pulmonary vein. So this was small cell. You can see it's extending into the right lower lobe at this point too, but pretty scary mass that, you know, if you don't know, if you're not attuned to the looking at the mediastinum, I think the lateral is easier to see it even than the PA view, that it can be easily missed. So I will stop there, Jeff.
All righty. Let's see what I can show here. I'm gonna go back. All right. Well, this was an interesting case that we don't see very often. I know, Travis, you've shown at least one of these. So this was a 50-year-old woman who had a lobectomy. I forget which lobe it was. It was one of them for a lung cancer, and immediately post-op, she was doing okay, and you can see she's got a pleural drain in, and we see a small postoperative pneumothorax, and there's opacity at the left base, but not too soon after surgery. She's already partially upright. And then what happened over progressive days, so this was her, let's see, later the same day, about 12 hours later, and you see smaller volume on the left, it's getting a little denser down that left lower lobe. We'll jump ahead another day, and we can see it's not clearing up. The pneumothorax is persisting. And then finally, I'll jump ahead another day after that. There we go. So progressively getting denser here. So the question was, what could be going on? And so in discussing this, we were concerned that if it were edematous and she wasn't febrile or anything, that this wasn't infected, that there could be some perfusion problems with the remaining lobe. When you look at the orientation of this, it doesn't look like there's a torsion based on the airways you can see and the fact that we see the apical pleura there. And the patient was doing fine, but we did raise the question, could there be a perfusion problem in the absence of infection? It was a difficult surgery because she had pre-existing adhesions. It was done with a VATS. So we got a CT the same day as the last radiograph, which I will share with you. And we can see here that there's this collection anteriorly. So I believe this was an upper lobectomy. So superior pulmonary vein has been resected. Upper lobe pulmonary artery is gone. Then we see the lower lobe pulmonary artery is perfusing. But you'll notice the inferior pulmonary vein on the left is occluded, and there's some staple material in the general vicinity of it and all this soft tissue here. And then on the soft tissue, lung windows, you can see there's ground glass in there and a few septal lines. So, and then a postoperative hydropneumothorax. And the orientation of the airways is preserved following a lobectomy. So this is an uncommon complication, but can occur where the inadvertent stapling, or in this case, just occlusion of the vein right near the staple line. It's unclear if the staple went near it, but there was a lot of tissue stuck down there. And, you know, in the original op note, they did identify the inferior pulmonary vein, but we wondered maybe if there's some anomalous branch or something like that. So they ended up doing a completion lobectomy, and patient's doing fine. But I think, Travis, you showed, or maybe it was Brent, someone showed a case of a venous occlusion.
I showed one a long time ago. Yeah, it was a right lower lobe.
That's what triggered my memory, because I remember when we were looking at that, you had shown a case, and the lungs should become better aerated, especially as the patient's up and about, and this one was not getting, it was getting worse aerated. It's just interesting. It took several days to really declare itself. It was never normal.
Yeah.
So you wonder if it was maybe just highly stenotic and eventually thrombosed or something like that. But in the second op note, it had some ischemic injury. It looked angry and not happy, so they took it out.
Jeff, could we look at the lung window on this image?
Of course.
Is that it does look pretty congested down there, doesn't it?
It does, yeah. I'm surprised there's not more septal thickening, but it's what it is.
Okay, and so you said they took out the lower lobe then, and so
there was a complete pneumonectomy because it was not salvageable.
Okay.
Yeah, these are always the tough ones when you're reading these post-op radiographs, because you don't want to say that the surgeon screwed up. At what point at what point is it no longer just a little bit of like contusion or even a pneumonia versus something they screwed up on?
Yeah, or in this case, there were some complicated patient factors, a lot of adhesions. When you're doing a VATS, it's a small corner near that hilum, and it can happen. So
I think the helpful thing on the CT is to see how puffy those vessels were. Those were really distended.
Right. And you also
vessels.
Yeah, the fact is just the vein is just gone.
Right.
Yeah.
This is a crazy case, and I can't wrap my head around it. And so one of my residents actually picked this up. So this was a trauma case. So he was a worker, and he fell from a ladder, and he landed on his feet. So he had a typical calcaneal fracture. He had a tibial plateau fracture. Nothing horrid, but I mean, still not great, but really confined to the lower extremities. And but they did their pan scan trauma, and my resident picked up this very low, extremely low attenuation filling defect in the right here, which I was trying to see if it was streak artifact or something that was at least affecting the attenuation. Clearly, there's something there. If you look on a sagittal, I'm going to go the wrong way because I always do. But let's see if I can find it on this side. There it is, right there. It's clearly branching, and it's fat. So, it's a fat embolus, I suppose, but I just can't wrap my head around where this gigantic blob of fat came from, given it was a calcaneal fracture and a Schatzker 1 tibial plateau fracture. There wasn't a huge vascular injury. And with fat embolism, we think of micro droplets getting somehow into the capillaries or the venules that then make their way back to the lung. But this would have to be a sizable vessel. Have you guys ever seen a true fat embolus?
No, this is the first one. I mean, it's been reported.
Yeah, and sometimes we get streak artifact that causes. But I mean, if you look at the images, it's a good quality. There's not any really artifact coming out there. And this is as dark as subcutaneous fat.
You could repeat with a non-con and see that still.
Yeah, maybe gone by.
Right.
He never developed.
That's really interesting.
Yeah, he never developed a fat embolism syndrome with an acute lung injury. So it must have dislodged it somewhere and went flying. So yeah, that's one of those things you probably see it once and never again. So let's see. My colleague Daniela gave me this case, I believe. This is just an incidental anomaly of anatomy, one I don't think I've seen, or I should say I've not noticed. And this is a bronchial artery that has an anomalous origin. You can see here's the left subclavian artery, and then you can follow this artery back down along between the trachea and the esophagus, and then branching into the left hilum here, coming way down here. So just the left bronchial artery coming way off this left subclavian artery. It's probably been described. I didn't look into it very much, but I've not seen that. I don't know if any of you have ever seen it or noticed it. I'll take that as a no.
No.
Robust no.
Okay. Here's a good Midwestern special. So this is a variant of mediastinal fibrosis. And this patient had this hilar soft tissue here. And you'll notice this was a PE study. We see calcified lymph nodes all the time. I consider them a normal variant of the Midwest, and the hilar nodes as well. But this patient just has too much soft tissue around the hilum. And what did I show this case already?
You've shown some highlightis before.
Okay, then I already showed this one. I'm sorry, I lost count.
I don't know that it was this one though, Jeff.
Okay. Well, this one just the clue to making this diagnosis here is the absence of the inferior pulmonary vein on the right. I mean, there's absolutely no vein in that right lower lobe. I'm pretty sure I showed this one recently. There's some narrowing of the airways as well, but it's just a variant of mediastinal fibrosis, presumably from old histoplasmosis. What's unusual is there's some contralateral lymphadenopathy. I think that threw off on the initial interpretation, but it's, I think, because she aspirated at that point, and that was more reactive. But you'll notice the difference in attenuation. The fibrotic nodes tend to be a little bit denser than the reactive nodes. I think I showed that one already.
And was there anything in the spleen, Jeff? Was there?
Oh yeah, you always ask me that. No, yes. There's so little TB here that it's still histo. You don't need disseminated histo to get fibrosis. So,
okay, but you didn't see anything in that spleen there. It went by pretty fast for me.
So this one's for you, David, per your proto case from the previous week. So this radiograph was interpreted as a possible nodule here in the right lung, and this I don't know this patient. I don't know if they were from the U.S. or not, but had a name that suggested they might not have been born here. And so, of course, we might think of TB or something. I think it was a non-smoker, but questionable nodule here. And on the lateral view, you'll see there's this this was actually circled. Someone had annotated the image, but they had marked this area here. But I've got a great CT to correlate with it. If I can get it to actually, there we go. So there was no nodule, but what we did see was this extrapleural fat along the fissure here, and the fissure has a funny anomaly to it, and there's all this soft tissue at the hilum and some stenosis there, and that may be from old TB or something else not related. But I show this case because it's a great example of a pseudonodule from extrapleural fat along this fissure here. I think I can make a what do we call it? A racem, as Howard referred to at that time. You can see the pseudonodule here, correlating it with the radiograph. It's not quite the same location. There it is right there. But a pseudonodule.
Okay.
And you want
this is a pretty good one.
This is a variant of the superolateral fissure sign, proto.
Just with an anomalous fissure in the way. Here's the article that Proto published back in, let's see if we have to change it here. Let's see, here it is. You should see, this is the Proto article from 1982. And he describes a bunch of radiographs. Yeah,
we see this more and more often now that people have more chest wall fat to get sucked into fissures.
Yeah, exactly. And they've got some path correlation, and there's an old CT in here as well showing that finding. So anyway, that was just a pretty example. This was a fun case because I think we're finally getting pretty good at picking this up early. So this was a kidney transplant patient who had developed a cough and a fever. Now, the initial radiograph we got looked like this. Portable, new admit to the ICU, kidney transplant.
I'm not seeing anything yet.
Oh, all right. That would be a go-to meeting thing. Let's see. Do you see it now? Nope. How about now?
Yes.
All right. So we see consolidation, low volume loss in the right upper lobe, and a background of multiple irregular large nodules. And I think the important findings is we don't see pleural effusion. I mean, there could be one on the right, maybe, but we don't see a convincing pleural effusion. And we don't see we don't see paratracheal thickening. We can't say much about the hyla. But when we see consolidation, a lot of nodules, in Wisconsin, we think about blastomycosis, especially in some of our transplant patients who it's not an opportunistic infection, but they're more likely to develop disseminated disease. And this is an ICU patient. So clearly this looks infectious. And then we subsequently were able to get the older imaging. So she actually started back, let's see here, back in March, maybe with something out here on the right. It could be some overlap, but there may have been something peripherally on the right. And then we jump ahead about a week and a half, and her radiograph starts getting more abnormal. Now we see a bunch of little nodules, and that area is becoming a little more confluent. And she had a CT at that time from the outside that just confirms the findings. But a couple important things. So lots of nodules, a larger dominant nodule with a bunch of satellites around it, highly suggestive of fungal infection. And then the important findings for us that we have seen over the years is absent pleural effusion, and really the lymphadenopathy in this case is pretty modest. It's very minimal enlargement, something you never see on a radiograph. There's some thickening around the bronchus intermedius, makes you wonder if there's airway involvement as well. And this is the most recent image. You can see it's still pretty advanced, and this grew out the blastomycosis, so the budding yeast. Turns out the patient lives on a lake, and of course everything's pretty much just about thawed here, although we had a nice spring snowstorm last week across the state. But we see a couple peaks this time of year from this disturbed soil, but there's also a latency of up to 3 months. So we do see it in the earlier winter from fall exposures. But we've seen a fair number of disseminated cases in kidney transplants, probably because they're not as sick as some of the other transplant patients out and about, and there's more of them. And so when they come in, they often get bone, skin, CNS involvement. This patient's isolated to the lungs, but is very short of breath, has not been intubated at this point, but is on the appropriate therapy. But of course, amphotericin is very toxic to kidneys. So, but that's real for this disseminated. That's really your only choice.
So Jeff, she was a kidney transplant.
Yes.
Said. Okay. And this absence of pleural effusion, I think that may apply to our crypto Gadii cases too. There was a discussion of one of our cases that I showed a couple of years ago to this group, but it was rediscussed this last week. And I was going through the CT and remembered what you said about blasto not having much in the way of pleural effusion. I think you also said there's not much in the way of lymphadenopathy.
That is correct. In contrast to histoplasmosis, where we see a lot of lymphadenopathy, even sometimes out of proportion to the lung, the nidus in the lung.
Well, when this case was being presented this week, I brought that up with our crypto case. There wasn't much lymphadenopathy; it was just ordinary mediastinal nodes, and there was no pleural effusion despite a lot of lung consolidation. So I just wonder. I'm going to keep my eye on that and see if that pans out with other crypto cases. It's also a yeast. I mean, it's also little round things.
Right.
So maybe they're common.
I may look at that with cocci as well. Just fungal pneumonia in general.
I think cocci. I mean, I've seen a fair number of, not as much as you guys have on the West Coast, but our snowbirds seem to come back with it in late spring. The cases I've seen, they do get more lymphadenopathy than you see with blasto, but you don't see that pleural effusion.
Yeah.
That you'd expect to see with, say, a pneumococcal infection. Right.
Have you seen blasto with true miliary nodules? Because certainly this looks like it's a random distribution of nodules, or are they usually larger like this?
In general, they are larger. That's been my experience. The disseminated fungal infection, histo too. They're a little bit bigger. But I do have one case of blasto that was a guy who developed ARDS from it. He had true miliary nodules, but he was not immune suppressed. So it's possible that you get bigger nodules in the immune suppressed patients. But it's interesting, blasto, the incidence isn't any higher in immunosuppressed patients, but they get more severe disease.
The other thing is the long latency. So the average latency for the crypto Gadii cases is like several months. I think it's like 3 to 6 months.
Right.
Might be something in common too with your blasto.
Right. And in this case, you can see, or we do see up to 3 months. I mean, you can see this evolved over a few weeks in an immune compromised patient, whereas you'd think something more aggressive would blow up in a couple of days. But Yeah, the latency can be pretty long. 3 months has been described from exposure, and there's a lot of host factors. Sometimes they clear it. Most patients have some symptoms of sort of a flu-like illness, but a lot of it depends on how much yeast they inhale and how much of a robust response they have. So there's genetic involvement. It's very interesting. I've learned a lot about blasto in the past few years. One of our infectious disease docs is sort of an expert on it. So every so often he gives a grand rounds or something at one of the departments around here, and he shares some stuff. So like our Hmong population up in northern Wisconsin, so they're originally from Southeast Asia. They seem to be susceptible to blasto genetically, and just like with cocci, with blacks and Pacific Islanders seem to get worse disease. So there's clearly some genetic play in as well, but it's it's a great mimicker. It can look like cancer. It can look like a bacterial infection. So we have to at least think about it and then get it on everybody else's radar, because you have to make sure you send the cultures for fungus, and they usually find the budding yeast. And there's a urine antigen. I think there's a serum antibody they can send off as well. Okay, just lastly, since we have a little time, I'll show this case. This is just a crazy case. So here's the radiograph. Patient's had a cardiac surgery. You can see a coronary stent, and there's a big bump there. And then this is a comparison from 6 years earlier. There was a bump, just less conspicuous at the time. So the bump got bigger. And then this is a recent CT. And at the time, we didn't have really any history. We just knew the patient had some kind of surgery. And this is just the craziest looking left ventricular pseudoaneurysm I think I've seen. And you can see it almost gets into the wall tracking up here. There is a patch repair at the RVOT. So the patient actually had some previous heart surgery with a pulmonic repair. I don't remember the underlying abnormality. I think there was a VSD that was closed, and there wasn't quite enough. The repair wasn't quite ideal from lack of myocardium. So I don't know if this is just related to injury from that, or there's some underlying myocardial deficit or defect. But this is quite a large one down here. And then you see it what was odd to me was it's sort of this contrast tracking into the myocardium itself up along the anterolateral wall and towards the top here.
You have a non-contrast? Because some of that almost looks like it could be an old patch.
No, I don't, unfortunately. This is definitely a patch around the RVOT. I don't know how much of...
Yeah, but even some of that LV stuff looks like it'd be a patch. I agree. This is obviously a pseudoaneurysm. There's a narrow neck, and it's crazy case. But like that stuff near the LV apex, that almost looks like a patch as well.
It does look like a buckle, and there's some calcium there too.
Yeah.
Yeah. So they're trying to figure out how to repair this thing, because I don't know how much myocardium is there to work with. But it's a good example of a radiograph. I've seen one like anterior wall aneurysm where you just get that bump. Yeah. So any patient that has an abnormal heart and prior surgery, that's certainly what you have to think about, an aneurysm or pseudoaneurysm. There's your core.
That's crazy.
Yeah, it's just a crazy one.
So what was the RVOT surgery for?
I don't know. There was a previous VSD, and this is an older patient. We didn't have any history at the time. So I don't know if there was a previous infarct. I mean, there is a coronary stent that led to a muscular VSD, if there was something congenital going on. But I suspect I think there was a VSD, pretty sure that had something to do with it, and maybe some involvement of an abnormal pulmonic valve. Yeah, unfortunately, we sometimes get these transfers here with all the images and none of the data.
So, Jeff, you think the VSD was an infarct-induced?
That's what I wonder, because it's not in the usual location of a perimembranous one. It was, as Travis pointed out, it looks like a big patch down there, so it may have been a post-infarct one that they patched, and it broke down because of myocardial ischemia or myocardial death. Okay.
Great. Excellent. We managed to fill an hour there. That was great.
Yeah. All right, guys. Well, thank you. I'll talk to you next week.
Thanks.
Bye-bye.